Thank you, everyone. It is now 30 minutes after the hour, and we'll now reconvene the meeting to begin our oral public comment. I'd like to welcome and thank our public comment speakers today for addressing the committee. All the speakers submitted a request in advance of today's meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And as a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at today's meeting. Thank you again to our speakers, and we look forward to your comments. Our first public commenter for today is Dr. David Wiseman.
Thank you very much. CDC and FDA's extension of the bivalent booster EUAs to the young children without VRBPAC or ACIP votes exudes regulatory steamrolling that avoids questions about extrapolations from data described by FDA as preliminary, imprecise, and potentially unstable. The use of not scientifically established immunobridging data per FDA, the relevance of extinct Wuhan and BA1 strains, and BA45 data based on as few as 8 mice. CDC asserts that FDA says that these vaccines are safe and effective. No, the EUA standard may be effective, which FDA have lowered further. FDA have introduced a 2-month boost interval, likely due to evidence of negative efficacy by 3 months. Does this signify immunological harm? ACIP's efforts to revise this interval were rebuffed, despite other examples of CDC modifying FDA decisions. mRNA vaccines are not flu vaccines, which are not gene therapies that turn your body into a factory for a toxic spike protein. Questions asked by VRBPAC's Dr. Portnoy and ACIP's Dr. Sanchez about the locus and duration of spike production and crossing the placenta have been repeatedly evaded. FDA's guidance on variant vaccines applies to monovalents made by a prototype process. Bivalent production raises significant QA safety and efficacy implications. At the last ACIP, Moderna revealed that the 2 mRNAs in their bivalent product generate heterotrimers. Is their vaccine tetravalent with 2 homotrimers and 2 novel heterotrimers with unstudied pharmacology and toxicology? Today's pregnancy discussion spotlights CDC's recommendations that circumvent manufacturers' off-label claims outside of FDA-approved instructions, stating that the data are insufficient to inform vaccine risks in pregnancy. If the data are robust, let FDA modify the label. More concerning are two VSD studies, 1346 and 1345, including some of today's presenters, which stated pertinently, now that the pregnancy is not a contraindication, there is an urgent need to monitor the safety of these vaccines during pregnancy. You cannot recommend a product saying it is safe without informing patients of the urgent need to study its safety and seek to waive the requirements for informed consent. Alarmingly, since the conditions appear to have been created where not only pregnant women participated in the study without their knowledge, they may have been coerced to do so by federal and other mandates. Along with CDC's ignoring safety signal studies by NIH, scientific standards have been eroded beyond recognition and ethical standards may have gone the same way. A more robust discussion of the safety and efficacy of these products must occur, including before they are added to the VFC program. ACIP members, please demand answers, and thank you for your work.
Thank you for your comment. Next, we'll move to Ms. Catherine Falk.
Hi, good afternoon. I am Catherine Falk, a parent and vaccine advocate in Oakland, California. I see you have a lot of business to get through this week, and thank you for all that you do. I want to focus on the portion of your agenda concerning the Vaccines for Children program. VFC is a valuable tool for ensuring that children have access to vaccines regardless of their family's insurance status or ability to pay. In the disruption of the pandemic and the economic turmoil of rapid inflation, this program is more important than ever. Routine vaccination rates slipped somewhat during the pandemic in the United States, and it's crucial to get back on track, especially now that most pandemic precautions such as masking have been dropped and emergency funding for COVID-related expenses is nearing its end. For these reasons, I strongly support the addition of the COVID-19 vaccine to the list of routine childhood vaccines that VFC will pay for. Learning to live with COVID means ensuring all children are protected from it and making sure money isn't an obstacle. is so important for families. There's no good reason not to add the vaccine, no good reason not to help families afford preventative care for their children, no good reason to let a single child miss a vaccine because their parents couldn't afford it. As I was sitting down to write this comment, I saw that Tucker Carlson decided to take aim at the VFC and at ACIP and the CDC in one of his tweets. If I could address him directly in 10 words or less, I think I would say, shame on you for endangering children and public health. I am sorry he has made your job that much harder with his fear-mongering. The work of combating misinformation continues. To those misled by Tucker's tweet, no matter what he says, only states can mandate vaccines for school attendance. Thank you.
Thank you for your comment. Next, we have Mr. Burton Eller. We'll move on to the next public comment speaker and come back. The next public comment speaker is Bob Runnels.
Hello, Bob Runnels. I'm a Washington State parent, extremely concerned about the health of future generations. This committee has been very successful at injecting children, usually against childhood diseases. The CDC has continued to add to the vaccine schedule since 1986, when liability protection was granted to vaccine makers. Today, families who follow the schedule will have their children injected 54 times with 73 doses of antigens for 16 diseases before they graduate. Since 1986, there have been no commensurate improvement in the overall health of our population. The US ranks poorly in many categories with very disturbing trends like the unexplained autism epidemic. Now, the elephant in the room. COVID is not a childhood disease. COVID vaccines, which I will refer to as COVID shots, are not medically indicated for the young. Their amazing immune systems can be strong if not hampered with. What's more, it is now widely acknowledged that COVID shots don't stop transmission. So it cannot be said that these shots save others from getting infected. The marginal benefits from these shots wane quickly, faster than for any other injection on the schedule. COVID shots are not well targeted to circulating variants. I don't care how fast trials are conducted, even mRNA technology cannot be fast enough to address a new microbe, except for maybe when using gain of function of dual-use research. So many of the public see what's going on. We notice when the vaccine definition was changed. We notice when the phrase vaccine failure was changed to breakthrough infection and immune escape. It's all vaccine failure. We've seen the death certificate criteria change to favor COVID death rates, confounding from and with. We see the huge government-funded efforts to market these products in TV, radio, print, billboards, online. Shouldn't they sell themselves if they're so good? The majority of parents know their kids are not at measurable risk, yet the public health apparatus tries to convince us otherwise. Parents see and sense that something is wrong. Our radar is pinging. We see other countries like Sweden and Denmark with very clear policy shifts against injecting children. Does the CDC consider how other countries are making their decisions? Yet there's this rush to recommend kind of approved COVID shots for ever lower ages. We see the ACIP as one of the many government bodies and private interests bending rules to mandate COVID shots. We know the CDC childhood schedule is the golden goose, granting liability immunity to pharmaceutical companies who, by the way, do all their own testing. You must vote no on any new shots to any of these schedules for COVID or other diseases. Our young little pincushions are already exposed to too many attempts at artificial immunity. To reduce risk, the ACIP should be finding safe ways to reduce the childhood schedule as VPDs diminish. 4 polio shots? Really? Vote no in adding vaccines to shots in any schedule. Be extra critical of the studies and talking points aimed toward you. The data must be overwhelming if the committee adds anything to the already bloated schedules. Vote no.
Thank you for your comment. Your time has expired. We'll move on to the next public comment speaker, Thayer Phillips.
Hello, my name is Thayer Phillips. I am the national spokesperson for Seniors Speak Out and have been an advocate for older Americans for over 25 years. I appreciate the opportunity to speak today and thank the committee for the extraordinary work and dedication they have provided over these last very difficult 2+ years. Before I go on, I want to say that I recognize that there have been important discussions this morning that I want to acknowledge and assess. I ask the committee to keep in mind that the clearer, the simpler, and the more direct the language, the better patients will understand and the better the chances will be for higher rates of vaccination. We find ourselves today in a situation so much better than we could have imagined in those early awful months of the pandemic, when fear and lack of both effective treatments and preventive measures took an unimaginable toll on people from all walks of life, especially older Americans. ACIP's prompt action in prioritizing older Americans' access to COVID vaccines saved lives and prevented hospitalizations. How far we have come. But the fact remains that there are still serious public health challenges facing men and women of advancing age. As 2022 nears its end, we worry not only about whether there will be a spike in COVID, but also about the impact of flu and pneumonia, whose persistence carries on decade after decade, with pneumonia remaining one of the top 10 causes of death for older adults. Reports forecast that flu season is very likely to be bad this year. So it stands to reason that now is the time we must prepare ourselves to do everything we can to prevent these old foes from overwhelming those of us who are the most vulnerable. Before COVID, pneumonia caused approximately 1.5 million annual emergency room visits and nearly 50,000 deaths. Though today we see these statistics through a post-COVID lens, we must not forget they are truly horrific. And it is equally important that we remember that there are ways to change them for the better. We urgently need access to the updated pneumococcal vaccines that FDA approved last year. Older adults who are previously vaccinated with earlier pneumococcal vaccines need to know when and if they can be given the newer versions. This year, this season, we need them more than ever. Please act today so that this effective protection is available before another winter season takes its toll. And please, once again, the clearer and the simpler the recommendation, the better for the provider and the patient and the outcome. Thank you.
Thank you for your comment. We'll move on to our next public comment speaker, Mr. Mark Gibbons.
Good afternoon. My name is Mark Gibbons. I'm the president and CEO of Retire Safe, an advocacy organization which represents the concerns of middle-aged and older adults. As we navigate a third year of the COVID pandemic, healthcare concerns have quickly risen to the top of our priorities. A bright spot in this difficult time is how older Americans have really embraced the protections offered by the innovative COVID-19 vaccines, with 95% of Americans aged 65 and over having received at least one dose of the vaccine. While we continue to communicate around the very real threat which COVID-19 poses to the respiratory health of older Americans, we have also remained steadfast in ensuring our community understands the risk of other diseases such as influenza, pneumonia, and RSV. Even before the pandemic, we knew that older Americans are more likely to become seriously ill and die from respiratory disease such as the flu and pneumonia. Today, as we continue to also face the unpredictable COVID virus, older Americans are feeling incredibly vulnerable and are seeking to take advantage of any way they can to protect themselves. This is why we are hopeful that the committee will vote in favor of recommending the use of the new pneumonia vaccines in those Americans aged 65 and older who have already received a previous dose. Our community listens intently to their physicians when it comes to how to best protect their health. By offering a clear and simple recommendation for providers on the use of the new pneumococcal vaccines for older patients will go a long way toward reducing the burden of the disease on some of the most vulnerable members of society. Just as older Americans aged 65 and over have embraced protections offered by the COVID-19 vaccine above any other age range, we believe that a vote today to expand access to the new pneumonia vaccines would also be welcomed by this community as another important tool that they can use to support a long, healthy life. We are grateful for the committee's ongoing efforts to protect Americans and especially American seniors. For our part, we will continue to educate and inform our communities on the important steps they can take to protect themselves. Thank you.
Thank you for your comment. And we'll go back to Mr. Burton Eller.
Thank you. We had trouble getting the link out to the country in rural America. My name is Burton Eller, and I'm speaking today on behalf of the National Grange. the nation's oldest organization representing agricultural, rural, and small-town American life. Today's discussion on the qualified guidance for the use of the pneumonia vaccine hits particularly close to home for us. Our own National Grange president, Betsy Huber, is currently recovering from pneumonia. She's doing very well now, but was very sick and was very grateful to have had the vaccine so that it wasn't any worse. Suffice to say, we are very concerned to hear this morning's discussion on the additional assessment for the use of the new broad pneumonia vaccines for individuals 65 years and older who may have already received a dose of the vaccine. In rural states and counties across the country, Americans are living in a risk of serious respiratory illness. Rural Americans are 42% more likely to die from COVID than their urban resident counterparts. And just before COVID, the rates of influenza and pneumonia were higher in rural counties than in urban. Two factors contributing to this are the fact that more Americans living in rural communities are older and access to care is limited. Since 2015, 183 rural hospitals have shut their doors. Nearly half of those still in business face negative operating margins, and 1 of every 4 are now at risk of closing. And on average, rural Americans live twice as far from a hospital than those living in urban areas. Because of this, we believe vaccines are a critical option for protection of those living in rural communities who are more vulnerable to serious respiratory illness or death. The National Grange recently signed a letter to Dr. Melinda Wharton, along with 21 other aging, consumer, and patient stakeholder organizations, expressing our support for clarified, straightforward guidance on the use of the newest pneumonia vaccines. We are grateful to the Pneumonia Working Group for evaluating the need for this clarified guidance. Rural Americans already face so many barriers to care, so we ask that this committee keep in mind that those patients need their physicians to have clear recommendations from the CDC in order to provide a comprehensive care, as comprehensive care as possible during the limited time they may have with their patients. We are grateful to the committee and hope it will vote in favor of the most straightforward recommendation for these new vaccines so that these Americans who would most benefit from this added protection are able to do so. We thank the ACIP for your work on these important vaccines and will do our part to make certain rural Americans know what could soon be available to them. Thank you.
Thank you for your comment. I want to thank all of our public comment speakers for today, and I also want to thank those who take the time to submit written public comments via the CDC docket as well. And with that, we will now move on to the voting session. We have first, we will look at the pneumococcal vaccine votes, and there are 3. We're going to go ahead and do VFC first, per Dr. Wharton. I'm delighted to switch up the order. Okay, so if we could please put the VFC vote language up. Thank you so much for your flexibility. Thank you. So this is the vote language that was moved and seconded to approve the Vaccines for Children resolution for COVID-19 vaccines. I'm going to ask at this time if there are any additional questions or issues the committee would like to discuss before this vote. I don't see any hands raised. Let me just confirm. All right, I don't see any hands raised. So I'll assume that the committee has no objections to proceeding with a vote. I'm going to ask the ACIP members to please turn on your video. And I will ask you to state your name and whether you have a conflict of interest, and then your vote. Just hold on one moment. I have to turn on my video. Thank you. We'll go ahead. So Just one moment, we're going to wait till everybody can get their video on. Thank you. We'll start the voting with Dr. Talbot.
Talbot, no.
Kip Talbot, no conflicts, yes.
Oh.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
I'm going to check to make sure folks can hear me. I'm going to actually move to Ms. McNally.
McNally, no conflict, yes.
Thank you. Dr. Bell?
Bell, no conflict, yes.
Thank you. Dr. Lair?
Lair, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Daly?
Matt Daly, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Shaw?
Shaw, no conflicts, yes.
Dr. Long?
Sarah Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, yes.
Dr. Cineas?
Cineas, no conflicts, yes.
Dr. Paling?
Paling, no conflicts, yes.
And Lee, no conflicts, yes. This vote now passes with 15 yeses. Go ahead, and 0 noes.
Yes, the vote passed 15 zeros, or 15 for, no against.
Excellent. Thank you. We will move on to the next set of votes, which is the pneumococcal vaccines. If we could please bring up the vote language for the first vote. Let me just confirm. Dr. Kobayashi, thank you. I just want to confirm. So is this the original vote language that we made a motion on? Okay, let's review the original language, and then I know that there was discussion that our colleagues wanted to have around the wording.
Okay, so the first proposal was adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended, to complete their pneumococcal vaccine series. This was the original presented this morning.
Thank you. And after the discussion that was that we had earlier, could you please put up if there is revised language?
Yes. Could you go to the... Okay, so the revised language after the discussion this morning is adults who have received PCV13 only are recommended to complete their pneumococcal vaccine series by receiving either a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended. And then the sub-bullets clarify which population we are talking about. Adults aged 19 to 64 years with an immunocompromising condition, cochlear implant or cerebral spinal fluid leak, and adults 65 years and older who have received one PCV13 only. And so the changes are, we put forth the recommend to complete their pneumococcal vaccine series to the front, earlier in the language. And then we also put either or to make clear that there are two options to complete the recommended series.
So I just want to clarify that the vote language is what's in italics, the part up top, but we did ask, per Dr. Lehrer's comment earlier, to just clarify in the accompanying text which groups this would apply to. So we anticipate the vote language would be the italics up top. I'm getting a yes. If amended. Dr. Talbot.
So just to clarify, so if you're a diabetic or a smoker, are you not eligible to get PCV 20?
Dr. Kobayashi?
Yes, thank you. So if you were diabetic under age 65, these people were not recommended to receive PCV 13 previously, so we're going by the groups who were previously recommended to receive PCV 13.
But it was my understanding when we voted for PCV 15 and PCV 20 that we combined all the high-risk groups under 65 years of age, and that included those with diabetes and smokers. So I'm a little worried that now we're pulling them out and making it more confusing.
Dr. Kobayashi?
Sure, I can answer that. Yeah, thank you for that question, Dr. Talbot. So yeah, so those people were previously recommended to get PPSV 23. So we do recommend PCV 20 or PCV 15 for those adults. And then if they're vaccine naive, then those people are recommended to get PCV 20 or PCV 15, including those who are diabetic, chronic heart lung disease. So we're only talking about those who received PCV 13 based on the previous recommendation.
Dr. Paling, did you want to add anything? Dr. Long.
What this says then, if you give the option of PPSV 23, that those who took that option would then need to get an additional dose of 20 at age 65.
Dr. Paling, would you like to respond?
Is that what was intended?
Or Dr.
By keeping the PSV 23 in there is a little bit confusing.
So yes, so by PPSV 23 as previously recommended, so these people will continue to get PPSV 23 based on what's currently recommended. So that would include, repeat dosing and one and final PPSV 23 at age 65, if they go that route.
Dr. Brooks? Well, so actually, it's so great that we're having this conversation because I think we are further clarifying and making sure that we are not confused as we make this recommendation. Dr. Brooks, please go ahead.
And just simple clarification, we're not adding a new vaccine to the guidance, we're just replacing one with another.
Yes, that is correct. So currently, these people are recommended to receive PPSV 23, but then we're saying that alternatively, they can get one dose of PCV 20 and then complete their recommended series as an alternative.
And just as a quick follow-up, so therefore all the cost effectiveness data, was it this? This is what we were looking at?
Yes, that is correct.
Dr. Talbot?
I now understand that that group previously had not been recommended to receive PCV 13, and I appreciate the reminder. I guess just for clarification, it might just be easier. I don't know that, I think everyone who's received PCV 13 in the past who's one of the high-risk groups, and if they accidentally got it or didn't get it or whatever the situation is, I just think it'd be more clear that everyone who previously received PCV 13 would be eligible for PCV 20. And without that, just the clarification confuses me. That's all.
So that's exactly the wording of this phrase. And then we're telling you the people who are most likely to fall into that category. And then as a reminder, we're trying to keep this broad because if some practices are not carrying PCV 20 and want to make sure people get coverage in whatever way is available.
Dr. Daly, and I'm going to encourage the conversation because I think the more that we can sort this out here, the clearer we'll make it for everybody. So Dr. Daly and then Dr. Shaw.
Yeah, I mean, I'm concerned about defining people by what vaccine they received as opposed to their age and their presence or absence of a chronic condition. Even though I understand the intent, because it's referring to a specific group, but to me that's runs the risk of adding to confusion. Over.
I'm going to go to Dr. Shaw and then Dr. Bell.
Thank you. One is two questions. One for Dr. Kobayashi. This goes back to the discussion earlier this morning about administrative simplification. Is it the case that a provider or a state health department in their Vaccine for Adults program, their view from an inventory management perspective could be simplified here because they need not carry both PPSV23 and PCV20? They could stop carrying PPSV23 and still provide recommended care for their patients. Is that's correct?
So that was something that was brought up by during the work group discussion in terms of inventory management. Exactly as you said, some providers don't carry the polysaccharide vaccine. In that case, they can complete the recommended series for these adults who started the series with PCV13 with a dose of PCV20. That's the intent of this recommendation as an option.
My other question, it goes back to the cost effectiveness analysis, and my colleague Dr. Brooks alluded to this a moment ago. I don't know how much that weighs on the decision or steers the decision here, because your slides from this morning also made a strong epidemiological case for the benefit of PCV20 versus PCV13. All that said, I had the impression that the cost effectiveness analysis presented a scenario in which the patient contemplated here, an adult who received PCV13, would get nothing rather than PPSV23. I'm not sure if that's A, correct, or B, the extent to which that alters the ultimate decision here because of the strength of the epidemiological data, but it is a question that's still on my mind.
Thank you for the question. So if the question was, what the model was actually doing, so there were actually, as you saw, multiple models that reviewed. So there were models that looked at PCV13 plus PCV20 versus no additional vaccine, but there were models that looked at PCV13 plus PCV20 versus PCV13 and PPSV23. So we considered all of that. We didn't present everything today.
Thank you.
Yes.
Dr. Talbot?
Yeah, I appreciated Dr. Daly's comment and was hoping that he could give an example of language that he thinks would be better. Not to put you on the spot, but I really liked your thought.
I'm going to give Dr. Daly a moment to think, and I'm going to call on Dr. Cotton, and then I'll come to Dr. Daly.
I just want to confirm, this doesn't seem to be accurate to me, because so I take care of immunocompromised patients, and if they had PCV13, then they are supposed to get PPSV23 8 weeks later.
Yes, so for PPSV23, it's 8 weeks later, and that's why we had to put or PPSV23 as previously recommended after PCV20 at least 1 year later. So that, the PPSV23 as previously recommended includes multiple groups. So there are the immunocompromised who gets it 8 weeks later. There are adults without immunocompromising conditions, but 65 years and older who get it 1 year later. So there are all these different groups, but we're trying to address this by saying, if you started a series with PCV13, but haven't gotten any PPSV23, you can get PCV20 as an option and just be done.
So I think that this isn't going to work in a clinical scenario because people won't understand that, and they don't know. I can, from my experience at my large academic hospital, people don't know where to find the information and then won't understand how to get this. And then we are very busy in clinic and won't have the time to look this up. So it can't be that many steps. And to me, I thought that this meant PPSV a year later, based on the wording. I do understand what you mean, but this isn't going to be clinically as useful as we would like. But Matt, Dr. Daly's going to tell us the wording that will save us.
I'm going to give him a break for another minute, and I'm going to call on Dr. Bell, and then I'll come back to Dr. Daly and Dr. Long.
Well, thank you. I'm not sure if it was worthwhile to call on me because my question may be completely silly, but I'm just wanting to make sure that we don't further confuse ourselves. I'm thinking about the third potential recommendation that we're voting on, which has a choice of clinical decision-making versus a recommendation. And are we adding to the group to which that is going to be applied by what we're saying here about people older than 65? I mean, it just seems like that's going to be like an additional confusion. If you are older than 65, you've only had PCV 13, you decide to get PPSV 23, and then you're also going to be told that you maybe should get PCV 20. Am I incorrect about this?
Dr. Kobayashi.
Thank you, Dr. Bell. So in the case of adults 65 years and older, if they got PCV 13 and a dose of PPSV 23 at or after age 65, then they're considered complete with the recommended vaccination series. So they will not be, well, it depends on what we decide on for the recommendation for adults 65 years and older. That's the third option. But based on the current recommendations, those, if you're 65 years and older, if you get PCV 13 and a dose of PPSV 23 at age 65 or later, then they're done.
Right, but I'm sorry, but that's my question. I'm just worried about considering this, assuming nothing else changes, if in fact one of the things we might change is related to this and is the third vote. Anyhow, that's what I'm concerned about.
Thank you. I think that's really good feedback. And before Dr. Daly even comes up with another recommendation, I'm just going to state that I think what we're going to do, and thanks to Dr. Romero for allowing this, but I would like to continue this conversation for the time we have remaining today. But I think what we're going to have to do is, consider if Dr. Paling and Dr. Kobayashi are okay with this, is another round of feedback, and we have time to vote tomorrow. I mean, I think our goal is to make sure this is as clear as possible for those who are delivering vaccines. And so again, I take this all as a positive, an improvement in a feedback cycle that will continue to make these recommendations clearer. So Dr. Daly next, and then I'm gonna go to Dr. Long, and then Dr. Lair.
So, I have a couple thoughts. I think one thought is I would second sort of, let's get the language right and then vote on it tomorrow to make sure that it's clear. A second piece is to say that we could take an approach of sort of identifying groups who are recommended for pneumococcal vaccination and then talk about a first dose and then a second dose, because I think sometimes that language will fit. And in this case, the second dose could be PCV 20, so that might work. And then a third suggestion would be that potentially we could put all three of the recommendations as I'm not sure it's a single, here's how we're recommending to change the recommendations, because as Dr. Bell said, changing one actually then may change some of the others too. So that's not exactly a solution, but it's at least a suggestion for a path forward. Thank you.
Thank you. Dr. Long?
Yes, I agree with that approach, Matt. I think we can't get away from the header being those who have received PCV 13 and say that there are several groups here. I mean, you should not have received it if you didn't have some indication, or maybe you got it by mistake, and you could name those groups and what you were meant to do, what the current recommendation is, and what you could substitute. And that would get you to the 1 year for the PPVS 23 or the 8 weeks, I'm sorry. You wanted to do that for the immunocompromised. I mean, you may truly have immunocompromised in there. You don't want to put them all into one bucket because these are all to take those buckets apart I think putting them into one bucket in this kind of is just more confusing than it is helpful.
Okay, let's keep going. Dr. Lair.
Thank you. I've spent a lot of time thinking about this, and my sense is that this is a transitional vote, that there are people who have asked the work group, this patient's got PCV 13, can they get PCV 20? And what we're saying is, yes, if you got your PCV 13, you can get PCV 20, avoid PPSV 23, you're done if you get PCV 20. So that's, in my mind, all this is. It's probably good for a year, and then hopefully no one will fall into this category anymore. I respectfully disagree with Dr. Daly. I would not lump these three policies because the third policy, in my mind, is a very separate policy that requires a totally different discussion. This is a very specific topic of, I got PCV 13, can I get PCV 20, or can I get PPSV 23? And yes, you can get either one. Whereas before, we didn't allow them to get PCV 20. We're saying, yes, now you can get PCV 20 to finish off. And then in a year, everyone will be finished off, and this will be moot. That's my impression of this.
Dr. Cotton, and then I'm actually going to call on Ms. McNally. And actually, since we are not going to vote today, I'm going to, you may turn your cameras off. I did turn mine off while we continue to have this conversation. Dr. Cotton.
Can I ask the working group, what data support this 1 year gap between PCV 13 and 20? And what happens if they're given 3 or 6 months apart?
Yes, thank you, Dr. Cotton. So we did review available, so only immunogenicity study data are available. So the shortest interval that we saw was an interval of 6 months between PCV 13 and PCV 20. And the reason why we settled with at least 1 year is because there is an immunogenicity study of PCV 13 series that showed that after the second dose of PCV 13 given 1 year later, the immunogenicity, immune response was actually lower for some serotypes compared to after the first dose of PCV 13. So there is some concern of some interference of the antibody. So therefore, at least 1 year is something where we thought we might be comfortable with for everybody.
Dr. Paling, did you want to respond?
And to further, part of the goal was to keep this as similar as to the current recommendation, which is that you can get PPSV and try to keep that on the same time frame.
I'm going to go to Ms. McNally, but before I do, I'm just going to ask my colleagues, if you still have a question, please leave your signs up. If not, please turn them over. Ms. McNally.
So I understand the need for this, but it is really complex. And I am concerned about what Dr. Cotton has said regarding implementation. And I am wondering if it's possible prior to a vote tomorrow, if we could see a visual aid that would be prepared for both vaccinators as well as the public to be able to understand this issue. Thank you.
Thank you. You received some nods in the room. We think that would be helpful. We're going to move to Ms. Bata.
Yes, and similar to what Jamie said, I think that we need to, in the language, include those who have previously started a pneumococcal vaccination series with PCV 13 before the new recommendations can finish it with this or this. I think that would be helpful. And the other thing is, the adults age 65 and older, are we supporting now the old recommendation? Because we had removed that recommendation for PCV 13 plus PPSV, and are we reinstating that?
Thank you for this question. So it's an interim recommendation in that the whole purpose of these proposed options are for those who started their series with PCV 13. So yes, we no longer recommend PCV 13 for who are pneumococcal vaccine naive, but we acknowledge that there are some people who were vaccinated based on the previous recommendation. So we're trying to, what we're trying to explore is whether the new higher valent conjugate vaccines can be offered to these people.
Any other questions or feedback? I'm just, for myself, and I thought the COVID-19 pediatric recommendations were confusing, but I have to say pneumococcal adults trumps this. So for me, I think what would be really helpful to me, I understand the recommendation is really to help simplify and clarify that completing a vaccine series with other available products is a very reasonable thing to do. I still find the original recommendations we had made years ago to be confusing. So I think, I just want to clarify the visual that could accompany this that would help me understand what exactly we're voting on would say something like, if you are a healthy adult 65 and older, you know, here are your options. If you are immunocompromised, here are your options. And if you're chronic medical condition, here are your options. Or is that more confusing? So my colleagues think that's more confusing, but I find that I need that.
I think that this is Dr. Lair. I think that it should say, if you started under the old rules, you may complete under these new rules. All those other things, this is all related to you started under the old rules. It doesn't matter whether you're immunocompromised or over 65. If you happen to start under the old rules, you may finish under the new rules. That's how I'm interpreting this.
Yeah, I think I'm okay with that language for the vote, just to respond. I would just say I would benefit greatly from a visual that would say, I am a person coming to see my doctor, what do I need? That would help me a lot. Dr. Daly?
Yeah, I mean, I think we're going to need to figure out a way to merge these then, because again, I would go back to the point that I understand that the intent is to complete the series with, but I think if I was either a patient or a provider in the office, I would try to find a 42-year-old with diabetes and then go from there. And then I could factor in whether that individual did or didn't get a PCV13, I think. But again, I'm a little bit concerned about defining somebody by what vaccine they received and then all that implies. I would feel more comfortable with age and condition, but then I don't know if that works, because then you have to say, and also did or didn't get a PCV13. That's the sort of old rules. I think I have a challenge trying to figure out how much you need to know about the old rules to do this right.
Dr. Hahn?
Yeah, thank you. Can you hear me okay?
Sorry, Dr. Hahn, we can't hear you.
You can't. Okay. Hold on. Okay, I switched my mic. Is that better?
Yes, that's better. Please speak directly into the mic, and I think we'll be able to hear you.
Yeah, thank you. Yeah, I just wanted to suggest, I think of all the, I've been on ACIP as a CST liaison for probably 15 years or so, I don't know. I think of all the recommendations, I agree with you. These are so complex and so confusing. Of anything that I've heard of, this would benefit from one of those tools where a patient or the provider could go in and put in age and then be guided through a series of, do they have these or these conditions? Have they received previous vaccine, and which vaccine was it? And then be told, based on all this, this is what they should receive. I think without that, providers are going to continue to be extremely confused about that. So I just want to put in plug for that, if that hasn't been already suggested.
Dr. Long.
Dr. Lee, do you think it would be helpful if we tried to answer the third question? If we answered the third question, and I'm confused if the third question is now part two of the first question, but if we answer the third question, then it seems we could have an overriding principle. Everybody needs to have PCV 20 when they're 65, and people who have not completed their series before that age can complete their series with PCV 20. we might have some overriding principle, but I totally agree with you. You need to have a group that's maybe frequently asked questions or frequently, the answers to certain individuals were certain strangeness, because some of these people, Jamie, are people who, I don't know why nobody knows why they got PCV 13. It might have been a mistake, or they might have wanted it, or they might have, I'm still a little confused what group we grouped with what, because somewhere along the line, it sounded like we grouped sickle cell disease with healthy in some kind of a recommendation. So
let me take that into consideration. Just give me a few minutes to think about it, and I will get back to you. Are there any other comments or questions? Oh, there's more. So let me go to Dr. Bell.
Thank you. Just to to Dr. Long's point, it seems to me, okay, so this recommendation is about people who happen to only have gotten PCV 13, and it's, cleaning up, like Dr. Lair is saying. But the third recommendation to me is actually a relatively big policy issue. Are we going to say that everybody over 65 for whom some sort of pneumococcal vaccine is recommended should all get boosted with a PCV 20? And to me, that's a much bigger issue than how we phrase cleaning up this group, which is an interim group that we don't really know exactly who they are or why they got PCV 13, but there they are, and they're asking if they can get PCV 20. So to me, that's a relative, how to do it is very complicated because these are all very complicated, but I don't think any of us necessarily, it's not as controversial an issue as this question of what do we think about everybody over 65 getting a dose of PCV 20. So I have that as, to me, it's a much bigger question. And the ordering of these recommendations in our discussions, I'm not sure if we're going to end up having to revisit things because we're waiting, in my mind, to address the larger policy issue to the end of the discussion.
Thank you. Dr. Goldman.
No, thank you. Appreciate being called on. I don't know if this helps or further confuses it, but from the primary care perspective, the previous recommendations, the chronic medical conditions would not have received the PCV 13, but as was alluded to, may have happened by accident that they got vaccinated. So in my mind, in some of the discussions we were having in the work group, it's more of kind of a do-over, as was mentioned, that we have PCV 20 now, which has a good immunological response, and that this kind of answers the question that whether you got PCV 13 or not, whether you should or should not have been given it for chronic medical conditions or whichever indication it happened to be given for, move past that, get the PCV 20, and now we can move on to continue the recommendations. I'm surprised that this one is engendering as much discussion as I thought some of the others would have been more controversial. But if that helps simplify from the on-the-ground perspective, what makes it easy for physicians will be whether you got 13 or not, move on, now get 20, and you're covered and you're with the guidelines, and that simplifies it without dividing it further into risk or age. This is just a cleanup for those who happen to get 13 for whatever reason, which they may or may not have been appropriate to have received that previously. Over.
Thank you. Are there any other comments or feedback? So this is my last round because I am going to go to break. So if there's anything else that people want to add or provide feedback on, please do so now. Dr. Talbot.
I also assumed, possibly incorrectly, that if you had received PCV 13 and then had received the polysaccharide vaccine, that you should still be eligible for a higher level of a conjugate vaccine. And I think one of the reasons I'm having trouble with this vote is that anyone who's received PCV 13, regardless of whether they've received PPSV or not, should be eligible for a higher for a new conjugate vaccine.
Thank you. I don't see any additional hands raised at the moment, so I'm going to actually take the opportunity to just state that I think we will plan to reconvene tomorrow with a vote. We will reconsider perhaps the order of the vote, because I think that might make it a little bit clearer if we were to start with vote 3 and then move to 1 and 2. And we'll defer to Dr. Paling and Dr. Kobayashi to lead us through, and we will hopefully be able to come to a cleaner set of recommendations and decisions tomorrow. With that, I'm going to suggest we take a 5-minute break. I'm sorry, colleagues. And we'll meet at, let's see, well, we'll take a 7-minute break, 35 minutes after the hour for our last session on polio. Thank you, everyone.